Good afternoon, and welcome to What's on the Horizon, Pain Management, Neuromodulation, and New Drugs for TN. I'm Melissa Bombick, the CEO of the Facial Pain Association, and I'm happy to welcome the chair of the FPA Medical Advisory Board, Dr. Ray Sekula. Dr. Sekula is a professor of neurological surgery at Columbia University. I'd also like to welcome Dr. Christopher Winfrey, assistant professor of neurological surgery and pain management specialist at Columbia University. Thank you both for joining us today. Before we get started, I'll ask that attendees submit questions using the Q&A feature on your screen. We'll get to as many as we can after the talk. And now I will turn it over to Dr. Sekula.
Okay, thank you, Melissa. I'm just going to, pardon me, I think I'll have to have you or Brandy pull up my presentation on Basm gland. But while you're doing that, let me just touch on a few items. First of all, Dr. Winfrey's an associate professor of neurosurgery. He's been practicing for many years, and I'm delighted that he could join me today. He is probably the biggest reason I moved my practice from Pittsburgh to Columbia, so it's been a great partnership working with him, and I appreciate him taking time out of his day to be with us. And I thought the last discussion was really excellent. And for anyone in the audience that felt like, well, I mean, you can feel however you want, but felt like, well, you know, it seems like people don't have an agreement on some of these topics. You know, that's part of what really pushes our field forward. These are experts. These are individuals who are deeply passionate about the surgery for patients with facial pain. And that's not new. You know, long before my time, 40 or 50 years ago, surgeons had strong opinions and kind of, you know, argued these points until we came to some consensus. And so I think it's very healthy, and I'm glad that it's persistent. And I hope that everyone in the audience knows that it's in the best interest of patients. Okay. Melissa, may I have my slides, or if not, I can do it without slides?
We are working on that. So
okay, it's no problem. So let me start by just saying I'm going to show just a few minutes of slides, and then Dr. Winfrey and I are deliberately not going to use slides, but that's not out of laziness. We've got lots of talks to give, but we really want to try to make it as interactive. So I'm going to ask him a few questions, and then Melissa is going to field some questions from the audience and ask him, and that's how we're basically going to spend most of our hour. All right, so if you could go to the next slide, please. So I'm going to speak for just a few minutes about this new drug available, which is called Basm. I think it's important to point out that I am not a paid consultant to Noema Pharma, but I am a site PI along with 4 other site PIs in the US. And then, of course, there's multiple sites internationally. Next slide. All right. And, you know, obviously don't want to make this too technical, but Basm is what's referred to as an allosteric modulator of the M5 glutamate channel. So basically, what allosteric means is that allo means other, steric means form. It means that when this drug is received by this particular channel, it changes the form of that channel. And then there are downstream effects that cause the electricity that occurs within that nerve to occur differently. Next slide, please. And this is just showing that there is, in fact, a buildup of the mGlu-R5 intracellularly in the cytoplasm and on the nuclear membranes. Next slide. And I'm going to just buzz through this. Next slide. Next slide. And again, there are 5 sites in the United States. So if you're interested in this trial, you can contact the Facial Pain Association. You can contact my office. We can get you set up with the closest site. Next slide, please. And these are the participating sites. And I should tell you, if you're looking at this and you're saying, well, gosh, I'm in Minnesota, there's nobody here. The company will reimburse you for travel expenses if you're an appropriate candidate. Next slide, please. And so in its basic form, there's a few items you need to know. First of all, you have to have either classic or idiopathic trigeminal neuralgia as designated by the International Headache Society and the European Academy of Neurology and the International Association for the Study of Pain. You cannot be above the age of 80. You cannot be younger than 18. You cannot remain on oxcarbamazepine or carbamazepine during the study. So if you're on those drugs and you want to do those studies, you'll have to taper off of those. You'll go through a screening process, but once you make the screen, so we've been enrolling patients for about 6 weeks and we've enrolled 4 patients thus far. You will get, during period 1 that you see there, you will get the drug for sure during that first 2 months. During the next 12 weeks or 3 months, you will at some point be randomized to either to a placebo. So it could come in week 2, or you might get the drug for another 10 weeks and get the placebo at week 11. Your site PI, such as me, will not know when you're randomized, but that's really the only way the company can determine, and the FDA, in fact, can determine if this drug is actually effective. And then after that, if you like the drug, the company will give you the drug at no cost for 1 year. Next slide, please. Next slide, please. It looks like, next slide, please. Okay, well, I don't, and this is how it works. So all of this you can find online. And I mentioned these inclusion and exclusion. I tried to hit the major ones, but if there's a major psychiatric condition not related to TN, you cannot be. If you actively have a substance abuse disorder, and then of course for patients with severe renal or hepatic problems that maybe couldn't clear the drug, you cannot be enrolled in the study. Next slide, please. You'll have to keep a diary. I have 4 patients enrolled. I have to say 3 of them are doing quite well currently, and the 4th is really just getting going. I don't have access to their diary, but there's a to-do list for you with this study. Next slide. And these are what it looks like. And I think I'm just going to pretty much stop there and let you all go. I really don't see this drug as a substitute for surgery, but there are, for at least in my practice, there's a variety of times when this drug makes sense. For example, perhaps we've done a microvascular decompression and it's no longer working, and we don't want to do an ablative procedure, or we don't think another microvascular decompression will work. That's when this comes in. Or for example, for me, and this is not true for every surgeon, if a patient has idiopathic trigeminal neuralgia and they don't have an obvious blood vessel for me to treat, then this is someone that I might consider this drug for. I think I'm just going to stop there, and I'm going to ask Melissa and Dr. Winfrey to return, and we'll get started. Melissa, do you maybe want to start the first question for Dr. Winfrey?
I do. If you don't mind, I'd like to ask you 2 quick questions about the study, and then we can move on away from that. You mentioned that there were drugs that you cannot be on. I think you said oxcarbamazepine and carbamazepine. What about gabapentin?
You can be on gabapentin.
Okay.
Yeah, and just to be clear, the reason that you cannot be on carbamazepine or its cousin oxcarbamazepine is because those are the most, generally speaking, for people with classical or idiopathic, those are the most effective current therapies. So it would confound the results of the study for you to be taking both.
Okay. And the other question was from someone who had visited the Noema booth on the platform and wanted to ask a question here about somebody who's not qualified for the study. It says, for someone who does not qualify for the Libre study, it was indicated last night that further study would be happening to ascertain safety for off-label use. Is there a way to keep in touch to kind of see the status of that?
Well, I think it's a really good question I didn't think of. I guess we should probably consider keeping people updated, maybe via the Facial Pain Association, like what's happening. We're obviously not permitted to give detailed results, and even I don't have those available to me. But I think we can probably tell patients, according to Amin Tahiri, who's a vice president of the company last night, this study is expected to be wrapped up by the end of 2024. So the hope is that this drug is available for patients by 2025. And at that time, once it's approved, and we think it will be, then your physician is able to use it off-label for you, even if you don't have classical or idiopathic trigeminal neuralgia. Because if you watch Dr. Liedtke's talk today, we use lots of drugs off-label. We, obviously try to be, prudent about it. But so I hope that answers it.
Okay. All right, Dr. Winfrey, we've had questions all day and even starting last night about neuromodulation. This one in particular says, is there anything promising, neuromodulation or otherwise, on the horizon for atypical eye pain? And I guess my question to you would be, what are the uses for neuromodulation? To answer that question as well, but then also more general uses for neuromodulation within facial pain.
So absolutely. And thank you for inviting me here, and to Ray and Melissa and the Facial Pain Association, and obviously to Randy and Natalie, who really made things run so smoothly. And then the attendees, and most of all the patients who've really sacrificed more than any of us during their facial pain journey. And it's great to meet everyone. It's really an honor to be here. And I know it's been a long day, and we're going to talk about neuromodulation. And today you've heard a lot about different facial pain treatments, heard from a lot of providers, a lot of some researchers. And it's been a long day, 2 days even. And it's, now we're getting towards the end. And similarly, the facial pain journey for a lot of you has been really long and frustrating. And a lot of you still can't get relief, even though you've gone through a lot of the steps you've heard so far. And it really takes a special person to stick it out. And I'm sure some of you have maybe even thought about giving up in this process. And what I would say now is, there are some hopeful things on the horizon, things we're actually doing now that are not available in a lot of centers, maybe some things you haven't heard of. And so I'd encourage you, those of you that are sort of late or far along in the facial pain journey, to be optimistic and try to stick it out. And today we'll explore some of these later stage pain strategies, such as neuromodulation and maybe some others. And we will get into the neuromodulation questions as we go through our sort of question and answer session today. Regarding the specific question of eye pain's a tough problem. And a lot of the peripheral nerve stimulation techniques we use really don't reach deep into the eye socket. So there are a couple of things that have been done to treat eye pain. And one, I actually tried several years ago. I talked to an acupuncture colleague of mine, and I asked them, if you were going to treat eye pain, where would you put the needles? And it turns out on the forearm, there's a spot on the dorsal forearm that when you put an acupuncture needle there, it can treat eye pain. We actually took one patient and actually placed a peripheral nerve stimulator at that acupuncture meridian, and it actually successfully treated his eye pain. The problem is he ended up getting a complication with the device. We had to remove it, and we never got reimbursed for it. So we weren't really able to move forward with that as a treatment option. So I can't say for sure that it was effective, but it was promising. And so I would encourage somebody who's doing research to maybe look at that moving forward. That's about the only thing I know of from a neuromodulation perspective that can really, potentially reach eye pain. So that's a tough problem, and it's tough in practice to deal with.
Chris, I'm going to ask you two questions. I want you to answer the first question second. First off, what is neuromodulation? But before I forget, the second question that I'd like you to answer first that I saw a couple of patients ask is, are there any drops available for people with eye pain?
Well, I imagine there's local anesthetic drops that are available, and there's likely topical sort of compounded medications that may have any of a combination of steroids or non-steroidals, or, there's ketamine, there's anticonvulsant, antidepressant drops. I personally have never prescribed eye drops, so I'm probably not the best person to ask about that. And I don't know to what extent eye drops will actually reach into sort of the deep eye socket pain, which is, I think, what a lot of people are referring to, rather than superficial corneal type pain. At least in my practice, that's what I've tended to see when patients have eye pain. So I don't know if the drops actually work for that deeper, that deep-seated eye socket pain. That's a good question, and I just don't know the answer to it.
Thanks. How about neuromodulation? What is it?
Yeah.
What is stimulation?
So, well, neuromodulation is the use of electrical or chemical means to modify the function of the nervous system. So either increasing or decreasing activity in certain pathways that are relevant for the generation and perception of pain, either with drugs or with electricity. So with electricity, you can place an electrode somewhere in the nervous system. You place a stimulator near the spinal cord or on a nerve, or you administer a drug into the spinal canal to administer medication into the nervous system to decrease pain levels. So neuromodulation is that process. Neurostimulation in particular is the specific use of electricity to accomplish that, that task, to alter function of the nervous system to change pain levels, presumably to reduce pain levels.
Can you explain to us what we saw this morning from Dr. Politzis when she treated the patient with occipital neuralgia and migraine?
Yeah, so occipital nerve stimulation is a neuromodulation technique where we place electrodes along one or more occipital nerves. The reason the occipital nerves are important is because they tap into the pain processing pathways of the body part above the neck, so head and neck area. So all of that trigeminal and occipital distribution sensation goes into a structure called the spinal trigeminal nucleus and tract. And the name's not important, but the point is there's a convergence of head and to some degree neck sensory information, including pain information, into this area. And if you can control the volume of the signals in that area, you can potentially reduce pain levels. And the occipital nerves tie directly into that sensory pathway. And if you can place an electrode along the occipital nerves, you can potentially dial down the volume of painful signals within the spinal trigeminal nucleus and tract. And that's why occipital nerve stimulation is thought to be a good treatment for a variety of pain syndromes of the head and neck area. So think migraine headaches, cluster headaches, hemicrania continua, sometimes hemicranial facial pain syndrome, so face pain coupled with back of the head pain, so half of the head, sort of the right side or the left side of the head. So occipital nerve stimulation is commonly used by some pain neurosurgeons to treat a variety of pain problems above the neck, say.
Thank you. Melissa?
There's a question here. I'm going to say the name of this drug wrong. I think it's clonazepam. Helps me cope, but does not control pain enough for me to participate in any activities. Does the fact that it helps a little bit give any clues as to what other medication might be helpful?
Absolutely. So I would say that clonazepam is what's called an anxiolytic. It's a reduction in anxiety. It's not really an analgesic, so it doesn't directly suppress pain. But what's fascinating about pain is that the nervous system has at least two separate pain pathways. There is one pathway that we all associate with pain. That's the lateral pain pathway. This is the pathway that tells us where the pain is, how severe the pain is, what's the quality of the pain. Is it sharp? Is it dull? Is it in my face? Is it in my tongue or teeth or fingers or whatever? It's sort of the geography of the pain. A parallel pathway is called the medial pain pathway. Equally important. This is the pain pathway that deals with the emotional content of the pain. So it's not how severe the pain is in terms of a number, 8 out of 10 or whatever. It's how much does the pain bother me? And that's hard to put a number on. That's how much does the pain bum me out? How much does the pain keep me from interacting with my family, picking up my kids or grandkids, you know, taking a trip? It's again, not a number, it's a quality. How much does the pain affect me emotionally, right? And so two very important pathways. And it's likely that the anxiolytics, clonazepam, are reducing some of the emotional content of the pain, making one less anxious about the pain. It may not even actually reduce the pain levels, but it may give you enough motivation to sort of get out of bed or get out of the house and do things, even though you still have the pain. And so the reason that's important is because there's a whole bunch of different medications that also affect the medial or affective pain pathway without necessarily affecting the lateral pain pathway. So these drugs may affect the emotional content of the pain without reducing the actual pain levels. So opioids actually are very powerful modulators of the medial pain pathway. A lot of times, I mean, obviously opioids can reduce pain levels, but sometimes they can't for neuropathic pain, but they can make patients a lot more comfortable with the pain that they have and allow patients to get up and get out of the house. Medical marijuana, interestingly enough, THC specifically, which is one of the impotent, one of the most important components of medical cannabis, that's a really, really good activator or modulator of the medial pain pathway. And there's some fairly new research that shows that THC reduces the affective burden of pain, which is sort of not surprising. I mean, a lot of people smoke up. Just forget the pain space for a second. A lot of people who use the drug recreationally use marijuana not to get high and sort of do crazy stuff or eat a lot of food or whatever. I mean, they do that too. But a lot of people smoke marijuana so that they can feel better about getting on with their day, right? They smoke to be less anxious. They smoke to be able to get up and not be depressed and go out and basically live a normal life. And so the reason for that is the drug is likely affecting the affective component of pain. So if you're a patient, to get to the sort of put a finer point on it for the questioner, if you're a patient who responds to medications that alter function in the medial pain pathway, then it might be worth exploring others. Medical marijuana, for example, or even trying a stimulator at some point, depending on where you are in your pain journey. Burst stimulation, which is a type of peripheral nerve or a type of stimulation we use in peripheral nerve and spinal cord stimulation, where there's bursts of high frequency stimuli followed by a pause, followed by another burst, followed by a pause. That specific waveform or type of stimulation specifically targets the medial pain pathway. And so a lot of those patients with burst stimulators will say that, you know what, my pain's better, but what's most important is my pain that I still have doesn't bother me so much. And that's pretty cool. And that can be life-changing for patients. So it's not only drugs that can tap into this medial pain pathway and reduce the emotional burden of pain, but it's stimulators as well.
Interesting. Okay, thank you. Ray, do you have a question or do you want me to go on?
No, go on, please.
How effective are, I'm going to say this word wrong too, intrathecal pain pumps? Is there any research regarding pain pumps for TN?
So there is a lot of data on pain pumps, mostly for back and leg and to some extent neck and arm pain. The majority of the literature has been for failed back surgery syndrome and to some extent complex regional pain syndrome, which is a neuropathic pain disorder that is typically seen in the extremities and sort of below the head and neck. There is some effort, including at our center, where we're starting to treat patients with craniofacial pain with intrathecal pumps. And a lot of times, for a lot of decades, the drugs that went into these pumps were opioids, which can be really problematic when given spinally for many years or decades. Not saying they're good or bad, but there can be a lot of side effects and they can be problematic. What's really interesting is that in the past 15 or 20 years, we've seen the development of a synthetic drug called Prialt. It's also called ziconotide, which is actually a derivative of the cone snail venom, which obviously they're not killing a bunch of cone snails and squirting that stuff into people's backs, but what they're doing is synthesizing a drug that mimics one of the compounds in that poison. And it turns out to be a really effective analgesic. And what's really interesting is that the drug does not have the same side effect profile as opioids. When you're on spinal opioids for years and years, and then something happens with the pump, and you forget to refill it, or there's a clot or a plug in the catheter, you can go into potentially lethal drug withdrawal. Again, it's a risk, like, anything can have risks, but if you can avoid that risk by having a different type of drug that doesn't have that problem, that's a good thing. And ziconotide doesn't have that risk. If you stop taking ziconotide suddenly after many years, you just get your pain back. There's no withdrawal, there's no, lethal complications. And also, we don't see the same sort of dependence you get on the opioids. That you just don't get that with ziconotide. You can start it and stop it almost at will. And so it makes it a lot less complicated, the drug. And so we're starting to see some groups in the US implanting pumps and catheters that infuse ziconotide slowly at a high cervical level, sort of near the head, to treat some of these craniofacial pains. And we consider that one of the primary salvage treatment options for patients at our medical center who've not had sufficient pain relief with the normal multimodal pharmacologic or drug strategies, or who've not done sufficiently well with surgery or stimulation or any of the other treatment options that are available. Sort of the end stage treatment we have at our institution and at others is to try intrathecal or spinal pre-alt. And so we definitely think it's a good option for patients towards the end of their facial pain journey.
Gotcha. Okay. Talking about pharmacologic solutions, there's a question about when a patient goes on a medication, what's the likelihood that they can stay on that medication long term, especially if they find immediate success? And I would say that for the most part, let's talk about the drugs that are most commonly used to treat facial pain.
I mean, my understanding is that I'll bet almost everyone who's a facial pain patient who's attending this already knows the answer. A lot of times you'll do well with the medication for a period of time, and then you find that beneficial effect fades over time. Now, it doesn't always. There are plenty of people who are on a stable dose of whatever, carbamazepine, for 10, 20 years, and they're doing fine. And there are plenty of patients who have the opposite thing, situation where they're on it for a few months and then it goes away. What percent, I don't know if I can put a percent on it, but there are definitely populations of both. I think the reasonable expectation is that what I suggest to patients is be optimistic. If you have a drug or a combination of drugs and it works, just enjoy those pain-free or well-controlled pain periods for as long as they last. And you can't predict the future. And if it ends up being 1 year and then you have to switch medications, that's 1 year your pain's under control. And if it's 10 years, then that's a decade where your pain's under control. And look at those as a win, right? And if you in 10 years have to look at another combination of drugs, then that's what you may have to do. But every few years, new things are happening. And I think the way to look at this is you give these drugs a shot and you give them the opportunity to help you for whatever period of time your body responds. And sometimes it does, and sometimes it doesn't. But I would probably not go into it thinking, yeah, there's a 50% or 60% chance that this drug's going to fail. I think that's probably not the right way to think about it. And I know it's easy for me to say, but I think having some optimism, because a lot of patients really do well with medications and don't ever have to have surgery. And I think letting the drugs do their thing and letting your pain doctors work with you to try to find the right combinations the way to go here.
Okay. I know we talked about neuromodulation a little bit, but there's a question about whether or not it might be effective on atypical facial pain, specifically in the teeth and jaw area. And I will say that throughout the day today and again last night, we hear about anesthesia dolorosa and what can be done for that. So I don't know that you have an answer, but I wanted to ask that as well.
Sure, absolutely. So let's talk about when you say atypical facial pain, I guess it depends a little on what you mean, but what a lot of people mean by that term is constant facial pain rather than the classic sort of lancinating trigeminal neuralgia pain. Mm-hmm. So what I would say is that neuromodulation is well suited for the constant or atypical pain syndromes. It tends not to work so well for lancinating pain. We have pretty good treatments both pharmacologic and surgical, for the lancinating pain syndromes. And although not every patient will get the relief they need, the overwhelming majority of patients will get relief of their lancinating pain through some combination of drugs or microvascular decompression, or the ablative procedures, the percutaneous lesioning procedures, the open rhizotomies, the radiosurgical procedures. That tends to take care of the lancinating pain. Mm-hmm. And so regarding the atypical pain, that's where things get trickier for patients, because those same treatments, the microvascular decompressions, the rhizotomies, the ablative procedures, tend not to work so well for the constant facial pain syndromes. And in fact, they may make a lot of them worse. So those suffering from post-herpetic neuralgia or trigeminal deafferentation pain who develop constant pain after an ablative procedure, or trigeminal neuropathic pain who have some sort of nerve injury and then may have some component of numbness, and they also have pain. If you damage that trigeminal system more, there's a chance you could actually make the pain worse, right? So that's when things get tricky. And those are the patients who do best with neuromodulation. So I would say if you have atypical facial pain or constant facial pain, neuromodulation should definitely be on your radar screen, at least before the ablative procedures, in my opinion. If you're not getting some initial success with medications in combination, that's what I would say. Now, anesthesia dolorosa is sort of the most extreme variant of a deafferentation pain. You've taken away all of the sensory input or sensory function of the trigeminal system in that affected segment, V1, V2, V3. And so it's anesthetic. There's no sensation. So someone who's anesthetic will not likely respond to a stimulator, right? You need to have some intact nerve pathways to pick up the electrical signals to then transmit them centrally where they can do their thing to lower pain levels. If there is no afferent highway for that information to travel because the nerve has been so damaged, then stimulation is likely not going to work. So in those cases, we would likely recommend either intrathecal pre-alt or one of the more centrally ablative procedures, which again is maybe a little bit beyond the scope of this seminar, but some of these things where we actually can lesion the brain to disrupt some of these sensory pathways, like a caudalis Dres procedure, where we actually lesion the midbrain, which is a pretty, invasive, and potentially morbid procedure that, again, in the right setting can be effective, but it's performed in very few centers, and it should not really be first on your list. It should be kind of last on people's lists of end stage treatments. And then there's something in between. There's something called a cingulotomy. Remember, I talked about the medial pain pathway, the affective pathway that THC works on, burst stimulation works on, clonazepam to some degree. The cingulate gyrus is a big part of that medial pain pathway. And so there are several groups of providers who actually perform a cingulotomy, where you can actually intentionally damage the part of the brain in the cingulate gyrus that transmits that information through the medial pain pathway. And again, that doesn't take away the patient's pain, but patients are often left with, I have this pain, but it doesn't bother me so much. I'm going to go grocery shopping, or I'm going to take a vacation, and that's something they couldn't do before the cingulotomy. So again, it's an ablative procedure. It involves intentionally damaging a very small part of the brain, but it can be life-changing for people. So again, anesthesia dolorosa might be one of those types of pain that potentially respond to that in the absence of responding to anything else. Okay.
What about pain management or new drugs, even for some of these more rare conditions, the rare conditions like geniculate neuralgia or glossopharyngeal neuralgia? How do you manage those?
So the pharmacologic approaches to all of these neuropathic pain syndromes is going to be largely similar. Like you're not going to exclude any of the drugs that are effective for one in the treatment of another. I mean, it's going to kind of be the same thing. Where these disorders differ in terms of their treatment is where you start thinking about surgical treatments, right? So glossopharyngeal neuralgia is similar to trigeminal neuralgia, except instead of cranial nerve 5, it's cranial nerve 9, the glossopharyngeal nerve. And so the anatomy is going to be different. Yes, there can be vascular compression syndromes. Yes, there can be viral or autoimmune neuralgias that can cause pain in the absence of vascular compression. And yes, the pharmacologic strategies are similar. The microvascular decompression surgeries are similar. Gamma knife can be similar. But it's just a different distribution of pain. It's a lot rarer than trigeminal neuralgia, but the treatments are fairly similar. There's some divergence in that there's a subset of glossopharyngeal neuralgia patients that are caused by compression of the styloid process, which is a little pointy, bony extension of the temporal bone in the throat, and that can actually compress the glossopharyngeal nerve. And that's called Eagle syndrome. When patients have that, they actually respond to resection of the styloid process, which the ENT surgeons can actually go through kind of the palate or inside the cheek and take it out without even causing a scar outside. You know, it can be a pretty effective treatment for it. Then obviously you don't have that option for trigeminal neuralgia. So there's some, you know, divergence there. Geniculate neuralgia, probably even rarer, and that can be, you know, a tough thing to treat. But again, the same sort of pharmacologic strategies are there. I don't know that there's a radiosurgical option or an actual surgical option.
Let me jump in on that. Thank you.
Ahead.
So the surgery, so for glossopharyngeal neuralgia, as Dr. Winfrey pointed out, there, you know, one culprit is the blood vessel. And if you have glossopharyngeal neuralgia, that's pain that starts deep in the throat and palate and radiates to the ear, and the MRI shows a blood vessel compressing the glossopharyngeal and the vagus nerve, that's almost always best treated with microvascular decompression. They do extremely well. Having said that, there are many patients with various forms of glossopharyngeal neuralgia that do not have a blood vessel, and they might have pain that starts in their ear and goes towards their throat, and I've had no success with surgery for them. So that's where we get into things like, you know, Eagle syndrome treatment, like Chris said, or different. We could do blocks of the glossopharyngeal nerve with steroids and anesthetic agents, and or the stereotactic radius surgery of the glossopharyngeal nerve. Now, nervus intermedius or geniculate neuralgia, and there's no difference there. The nervus intermedius fascicles run variably with the facial and the vestibulocochlear nerve, and they're referred to as either nervus intermediate or geniculate. This is another area of a lot of controversy. So the surgical treatment is either to move a blood vessel or to cut those fascicles. I've done quite a bit of that type of surgery many, many years ago. I've really gotten away from it because I don't feel that the surgery is as effective as it has been reported. But there are other surgeons that disagree with me. But in that case, in a lot of those patients with that deep stabbing ear pain that's called geniculate or nervus intermedius neuralgia, I'm often blocking with a steroid and anesthetic, or having someone block the auriculotemporal branch of the trigeminal nerve and the greater auricular branch, which is part of the cervical plexus. And I've found maybe a half of those patients respond very nicely, and that's been really gratifying. I'll let you keep going there, Chris.
Yeah, no, you definitely have a wealth of experience treating those neuralgias, which I don't actually, because stimulators can't really reach them, and so I don't really have the opportunity to treat those patients.
How about Megan, Melissa? I was just thinking about, anyways, please interrupt me, Melissa, but Chris, give me an example of somebody that you would use stimulation for.
So peripheral nerve stimulation is really well suited for patients with facial pain involving the V1 distribution, the forehead, or the supraorbital nerve distribution, or V2, the middle of the face, or infraorbital distribution. Those are the easiest nerves to approach with a peripheral nerve stimulator in the face. The lower jaw, V3, that's tougher, and the nerve is encased in bone and the jaw is mobile, so I've not found peripheral nerve stimulation to be particularly helpful for V3 distribution pain. But high cervical spinal cord stimulation, where the electrodes are placed somewhere in the thoracic spine and tunneled through the epidural space, advanced up to the base of the skull, occiput, C1, C2, C3 even. Those electrodes will then overlie the spinal trigeminal nucleus and tract, which I mentioned before, where a lot of the lower part of the face sensory processing actually dips down into the high cervical spine. So you can actually place an electrode over that area. And when you turn the electrode on, patients will feel tingling in the lower jaw. And that means you're applying electricity to that part of the sensory system, and you can actually reduce pain levels in that area. So peripheral nerve stimulation for V1, V2, and then high cervical spinal cord stimulation for V3. Those tend to be the best targets for peripheral nerve stimulation and spinal cord stimulation for facial pain. Anything in the occipital distribution or hemicranial pain is going to be better targeted with occipital nerve stimulation. So not primarily for the facial pain disorders, that's more for the headache disorders and for the occipital neuralgia disorders.
Okay, that makes sense.
I know, Chris, that we've had some efforts at this, but when do you think we'll see more routine use of trigeminal ganglion stimulation?
I think when a system's developed that's commercially available, FDA approved, and affordable by healthcare systems. A lot of this is cost, and I just don't know that we're there yet in that part of the body. Quite frankly, a lot of insurance companies are reluctant to pay for even some of the peripheral nerve stimulation systems. So it's not like that's a sure thing either with all insurance companies. A lot do, but a lot don't. And it can be a real effort. And some of the patients on this call may have been part of that appeals process where you're trying to get these things approved, and the insurance company is saying it's experimental, even though there's a lot of clinical data that supports their use. And the same goes for some of the newer trigeminal ganglion stimulators, which I think there's a lot of promise there. But when you're putting something in the mid face through a fairly mobile area like the facial muscles, I mean, things are prone to migrate or fracture or break, and that's really why it's taking so long, I think, to develop a reliable system, is purely for technical reasons. I mean, it's not like we can't access the area with a needle or a stimulator delivery system. It's keeping the electrodes intact so that patients can enjoy the relief long term without being burdened by a whole series of repeat procedures to replace broken electrodes and to move electrodes that have migrated. I mean, we're trying to get patients relief without tormenting them with a ton of surgeries after to fix the electrodes. And so I really think that's what's taking so long, and it's not an easy problem. But one day, we'll get there, and hopefully be able to get patients some relief. That's the hope.
Okay.
Thank you.
I wanted to ask a couple clarifying questions that came up in the chat and just make sure that people are really clear on particularly on neuromodulation. So somebody asked, is TENS a form of neuromodulation, and could it work for the atypical component mixed with classical? And then somebody else said, so is neuromodulation only for atypical? Yeah.
So TENS is technically a form of neuromodulation. You're applying an electrical current to a portion of the nervous system, in this case, the cutaneous receptors, which is where the sort of the sensory information starts in the skin, and to some degree maybe the small peripheral nerves immediately below the skin. So yes, it's neuromodulation. It's not implantable neuromodulation, so it's something that physical therapists can do, patients can do on their own. You don't need a surgeon to do that. I have not had a lot of success with TENS in facial pain patients for two reasons. One is most people don't want to walk around with TENS pads and wires on their face day to day. Now, a lot of people are totally content doing that when they're sleeping and not trying to be mobile and out living their lives out in the world. But everyone's different. If you try it and you want to do that, then that's great. What I've also found is a lot of patients with facial pain they're pretty sensitive to touch. They don't want their face touched, and putting in a pad on the face and having electrical current go through the skin with an adhesive pad really doesn't work out for a lot of patients with facial pain. Now, I'm not saying patients shouldn't try it, because I'm sure there's people on this call that have said, oh yeah, I've tried it, it works great, it helps me sleep at night. I say try it because it has essentially zero risk, and there's really no downside. You try it and you see if you're one of the people that it can work for. But in my experience, it doesn't work for most people for those two reasons.
Okay. I've seen this question come up, and I can't remember exactly. I don't know if it was even this talk, but about this particular question says, can you talk about removing an occipital stimulator that has been in for 10 plus years? And I feel like I saw another question about maybe a neurostimulator that was in that wasn't doing anything anymore or something like that. And so was it better to just leave it or take it out, or?
So it depends on the patient. I'm not typically in the habit of telling patients what to do. If I've had patients, I've put in occipital nerve stimulators, and I've been doing this for almost 20 years. And I've had patients come back 10, 15 years after the fact and said, you know what, my pain's gone, or I found a new drug that helps my pain, or I did an occipital nerve decompression or something, and they no longer need the stimulator. And that's fantastic. That's a success, right? Where patients don't need the stimulator anymore. That's a win. And some of them say, doc, what should I do? Should I just leave it in, or should I take it out? And I say, well, does it bother you? Is there discomfort around the hardware? Is it at all annoying having, or do you need to get an MRI scan? Because these things are not MRI compatible, unfortunately. They will be soon. The hardware is MRI compatible when they're placed in the spine, but they haven't been tested for MRI compatibility in the subcutaneous, in the skin of the scalp. So for that reason, it's not MRI compatible. And so a lot of patients say, look, I need an MRI scan. I'm not using the stimulator. Can you take it out? Taking out these stimulators is very easy. I say to patients, it's a 5-minute procedure, outpatient. It's easier and lower risk than putting it in. Anytime you take something out of the body, lower risk than putting something in. There's no risk of tunneling issues. You literally just open up the 2 incisions under local anesthetic, and you remove the wires and you remove the battery. I mean, it is one of the easiest and safest procedures I do as a pain neurosurgeon. So if you're out there and you have a stimulator and you want it out, or you need it out because you need to get an MRI scan or spine surgery or something else, it's not a problem at all. Easily removable with minimal risk of something going wrong.
Okay.
Chris, you touched on something about occipital nerve decompression. There are a lot of individuals attending the conference today who have various forms of trigeminal neuralgia and occipital neuralgia. Can you talk a little bit about that?
Yeah, occipital neuralgia is pain in an occipital distribution. It's often unilateral, so one side, or it's bilateral. It can sometimes happen both sides at once or one side at a time. And there's basically 2 rough patterns of pain. Sometimes people have constant pain. Just like in trigeminal neuralgia, there's people with the atypical constant facial pain. Same happens with the occipital nerves. It's pain that's kind of constant. Maybe it fluctuates, maybe it goes away, but it's kind of always there, or there most of the time. And then there are the patients with occipital neuralgia where they're essentially pain-free, but once in a while, maybe they turn their head a certain way, or they sleep on a pillow funny, or they hit an area in the back of the head, and then bang, there's this lancinating component of pain, which, if you think about it, sounds exactly like the story of people with trigeminal neuralgia. They're doing good, pain-free, and then bang, this pain hits them. Well, the same thing happens with the occipital nerves. And when we have patients present with the lancinating type occipital neuralgia, or I can examine the patient and tap on an area of the back of the head, or if the patient can tap on an area of the back of the head, and that reproduces the pain, that's normally from occipital nerve compression. And it can be compressed by a variety of things. Unlike the trigeminal nerve, which is almost always compressed by a vessel, rarely by a tumor, the occipital nerve is usually compressed by fascia, which is a tough covering in the back of the muscles in the body. And where the nerve pierces the fascia, it usually pierces the fascia with a number of veins and arteries, which can compress the nerve. And about 1 in 8 of these that I've seen in my surgical practice actually have a lymph node compressing the nerve. So when a patient turns their head a certain way or puts pressure on that area, that extra pressure from the fascia, a vein, or an artery or lymph node can then put more pressure on the nerve, reproducing that electrical sensation. So those patients often do great with surgery. So if you can reproduce the pain, push it on the back of the head, and you can block it with a local anesthetic temporarily, that kind of cinches the diagnosis. Those patients often do great with surgery, 80, 90% relief with surgery. Basically make a small incision over the nerve at that Tinel sign, or at that area where you tap on the nerve and it reproduces the pain. You almost always see something compressing the nerve. You open up the fascia, you take away the veins or the lymph nodes or whatever's compressing the nerve, and you just let the nerve relax with no pressure, kind of like doing a microvascular decompression. And those patients, again, have, similar to trigeminal neuralgia, something like 85% chance of good outcome. The ones with constant pain, that's a tougher thing. We don't normally decompress those. Those we normally recommend treating with medications, injections, and if that doesn't work, then an occipital nerve stimulator.
Okay. I have a question, and Dr. Skula, this might be for you, might be both of you can weigh in. What about new drugs for TN, specifically baclofen, CGRP antagonists, Nurtec, and Qulipta?
So baclofen is not a new drug. That's an old drug. It's been around a long time. It's not as old as medical marijuana, which has been around thousands of years, but it is a fairly old drug, classically used to treat spasticity, right? It is a drug that, it's a GABA B receptor agonist, as I recall. And what it does is it inhibits some of these interneurons or some of these modulating neurons in the pain pathways. And so by blocking those or activating these inhibitory interneurons, it can actually reduce pain levels. It's not known exactly how it works, but it probably is a similar mechanism to its use in spasticity, where you're sort of breaking these reflex arcs and relaxing muscles. You're kind of breaking the pain reflex arcs and lowering pain levels. So baclofen's been around a long time. It's taken orally. It's also used intrathecally in these spinal infusion pumps, and it can be a treatment for neuropathic pain. And it's something I recommend patients with facial pain try before going to stimulators, for example. It can be a great option, and it's usually well tolerated by patients. A lot of patients get sleepy, but usually don't have a lot of other like bad side effects. They can, but they tend not to happen. It tends to be a lethargy thing at higher doses. I'm not familiar with Qulipta and Nurtec. Maybe Ray knows.
Yeah, those are, you know, they're newer migraine drugs, and the CGRP antagonists they're in that family. And, you know, they are kind of an exciting area for patients to work with their doctors, with either their neurologists or pain management physicians. You know, as Dr. Winfrey said, you've got to, some of this has to be trial and error. You've got to try things. You know, it really depends on the type of problem you have. If you're an individual that has some facial pain that's clearly driven by, let's say, occipital neuralgia, you may respond better to these drugs than let's say, you know, probably, although we don't have great data on this, the classical trigeminal neuralgia patient due to vascular compression is not likely to respond real well to a migraine medication like that. And then, you know, the drug that was exciting a few years back was Vixatrixine, but the company gave up on it in the US. So that was a drug that was a specific sodium channel blocker, and that was an exciting drug, but looks like you know, they're unwilling to try to bring that to market. It's quite expensive, and that's why we're excited. And again, I am not a paid consultant to Noema Pharma, but that's why we're excited that there is a company that's willing to push forward for patients with trigeminal neuralgia in the form of Basm, which is an allosteric modulator of glutamate receptor, and you know, that's exciting. We'll have to see, you know, how it does for a whole lot of patients.
Okay. Well, I have one last question. We're getting to the end of our time, but Dr. Winfrey, can you tell us how occipital neuralgia relates to cluster headache?
So they are definitely different pain syndromes. Classic cluster headaches is usually in the temporal area, and it is not just the location of the pain, it's the pattern of pain. Patients with cluster headache usually have episodic pain, episodes of pain that may occur daily or a couple times a day, and they cluster together. You may have a couple of weeks worth of daily pain episodes, and then the pain abates for another couple of weeks or months, or, you know, whatever time frame. It can be different for everybody. And then the pain comes back after a period of time, and then it kind of goes away. It can be disabling, horrible pain, but it's not usually in the occipital distribution. It's usually in the temple, usually unilateral. Occipital neuralgia is in the occipital distribution. If the pain's not in the occipital distribution, the back of the head, then it's not occipital neuralgia, I mean, kind of by definition. Now, as I said before, the occipital nerves are an important component of that trigeminocervical complex, where that all that sensory information from the head goes into the spinal trigeminal nucleus and tract, and the occipital nerves tie right into that. So patients who have cluster headaches can actually do really nicely with occipital nerve stimulation, even though the electrodes are not placed over the temple. It can relieve that frontotemporal pain from cluster headaches by stimulating the occipital nerves, because of the relationship of the occipital nerves and the trigeminocervical complex, that pain processing center.
Excellent. Well, thank you very much. Thank you both for answering all these questions. We have a ton more, but you know, we're just really grateful that you took the time. We are at the end of our time, so attendees, please go back to the agenda and choose your next presentation. You have a choice during this next hour. Dr. Brown is talking about autonomic responses, and Dr. Stanton is going to talk about the use of auricular acupuncture in facial pain. So you can choose between those. Those will be our two last full presentations of the day. We'll have a wrap up that will kind of go through where the organization is going moving forward, and that kind of thing. But this will be the last presentation of the day. So thank you so much. We really appreciate your time.
Thank you, Melissa.
I wish everybody the best.
Thank you.